interferes with an individual's way of normal life. So surgery being one of the clinical activities, that elicits pain requires effective postoperative pain management so that the surgical patient can be effectively managed. And so inadequate pain control, just other than being inhuman, can result in increased cases of morbidity or even mortality. Next slide, please. So uncontrolled pain in postoperative patients. Uncontrolled pain in postoperative patients may lead to delayed wound healing, as it can also cause stress. It can make the patient anxious, depressed, and it can also interfere with sleeping cycles as well as feeding cycles. And prolonged pain as well in postoperative patients can damage the sensory nervous system, as well as lower inappropriate pain medication doses to such patients. Can lead to detrimental effects such as respiratory depression or even stroke. And so it's important that pain management in such patients is done appropriately and effectively. And looking at the justification of this study, as I mentioned earlier, uncontrolled pain amongst postoperative patients is one of the leading causes of morbidity and even mortality. And for this study, there was no previous study that was done to evaluate the pain management amongst postoperative patients at Thika Level 5 Hospital. And so there was need that postoperative pain patient, there was also no postoperative pain management guidelines in the public domain for management of pain amongst the postoperative patients that was available when this study was conducted. Now to the study objectives. This study aimed at evaluating the effectiveness of postoperative pain management at Thika Level 5 Hospital. So specifically, we were looking at assessment of the pharmacologic, the patterns of pharmacologic and non-pharmacologic interventions in the management of postoperative pain. We're also looking at the way the patients, we're also evaluating the patient's pain experiences and the interferences to function. We are also evaluating the adequacy of documentation of pain medications for postoperative patients, as well as looking at the level of patient satisfaction and perception about their postoperative pain management. So, next, please. Yes, thank you. So this study was done at Thika Level 5 Hospital, which is in Kiambu County. It was a descriptive, prospective cross-sectional study that was done amongst postoperative patients who are 18 years and above between the period of January and March 2020. Consenting postoperative patients who are 18 years and above were included in the study, while postoperative patients who are admitted in the intensive care unit, those who had difficulty in communication, those who were unconscious, and those who had documented psychiatric illnesses were excluded from this study. The data for this study was collected using an American Pain Society Patient Outcome Questionnaire, which had aspects which had aspects to look at, for instance, interference of pain with function. So that was one of the aspects that we are looking at. We are looking at if patients were allowed to participate in decisions about their pain relief treatment, if patients were satisfied with the results of pain treatment that they received, if the patients received any information about their pain management options prior to their pain management process or initialization of their pain management process, and if the patients used any other alternative methods of pain management other than the pharmacological ones, and if the use of this pain management, alternative pain management methods was initiated from the medical staff or from their own individual decisions. And so this data that raised using the statistical package for social sciences, SPSS, and Microsoft Excel, after approval being obtained from Thika Level 5 administration. Okay, so if we can go to the results. Next slide, please. Okay, so when the pain scales in the patient's files were checked for presence of pain scores and complete filling by the medical staff, only 9% of these pain scale sheets were completely filled, while 91% of these pain scale sheets provided in the patient records were incomplete. And then again, when these patients were asked about their level of satisfaction with pain management, only 71% of these patients agreed that they were satisfied with the pain management treatment, and 12% of these patients disagreed that they were not satisfied, while 17% of these patients were either partially satisfied or not satisfied at all, maybe for one or two reasons that they So again, when these patients were asked to rate their pain 24 hours after the surgery was done, on a scale of 0 to 10, 0 being no pain at all, and 10 being the worst possible pain, distressing pain, that's a pain score of around 5 to 6, giving a total of around 45% of the patients responding that had distressing pain. Again, another group of patients responded that they had intense pain. That's a pain score of around 7 to 8, accounting to around 40% of the patients. Next slide, please. Okay, thank you. Now, on assessment of the treatment sheets provided in the wards, we found out that tramadol was the most frequently used analgesic postoperatively, that accounting to around 44.2%, followed by morphine, which accounted to around 19.5%, and then concurrent use of tramadol with non-steroidal anti-inflammatory drugs was now followed after amongst other use of alternative methods of pain management. Use of alternative methods for pain management. In the next slide. Thank you. Use of alternative methods for pain management amongst the patients was done by majority of the patients. When asked, most of the patients said they either prayed or listened to music. Around 32 of them translating to around 28% of the patients said they used either prayer or they listened to music as an alternative method to contain their pain. Some of them say they listened. Another group of patients say they listened to music or they did massage. That's around 20%. And then 36 of the patients, that is around 31%, said they did not use any alternative methods to contain their pain experiences at the time of the time they were in hospital. Now, looking at these results deeply, the next slide, please. There was one there was a paradoxical high satisfaction, high pain experiences. We noted that 71% of the patients were satisfied with the way their pain was managed, while again we had very high pain scores, around 5-6 pain score and 7-8 pain score. So these paradoxical high satisfaction, high pain experiences are one of the things that were found from the study. And from reference from other studies indicated that a high satisfaction rate mostly was obtained when there was a high rate of preoperative education given to the patients by the medical staff, presence of a very good communication environment between the medical staff and the patients. And again, there was maybe a good caring attitude of healthcare professionals towards the patients, or probably due to presence of frequent pain assessments continuously throughout the period of pain management. So that's what other studies stated why there could be high satisfaction. But then for this specific study, majority of the participants who reported that they did not receive any pain management education from the medical staff, and information on use of non-pharmacological methods on pain management from the clinicians was very minimal. So most of them who did non-pharmacological methods was from their own initial initiatives or decisions. And then overlooking of the clinicians to patients' requests was the main reason for dissatisfaction by the 12% of the patients. So that was indicating probably a low level of communication between the patients and the medical staff at hand. And then the use of pain scales to assess the patient's postoperative pain during the first 24 hours and subsequent days was not evident. As we noted, only 9% of the pain scale sheets were fully or completely filled when they were checked from the files. And so again, something else that we noted from this study was there was still a high pain intensity 24 hours after surgery, even with the use of analgesics. And this probably could be accounted to the inadequate progressive pain assessment during the treatment process, as this will inform probably a review of the type of medication being given, the doses, and even the duration. That was the duration of time that these medications were being given. So this study recommended or recommends that there could be probably a further research in establishing the barriers. There could be a further research in establishing of the barriers to effective pain management process in the country or even in the facility. And again, the research suggested that there could be an adoption of a monitoring system just for documentation in so that as much as in the system available, they can just to check, there could be a way to check if these documents are efficiently being used, and the service delivery is also as per the institution's requirements. And then the study also suggested development of pain management and monitoring protocols just to synchronize pain, postoperative pain assessment and even management generally in the institutions. And then also there could be a comparative study just to compare, probably because this is one of these a study that was done just in one institution, to compare what other institutions are doing, one or two, and again what is the patient, the private sector of health. And in conclusion, as I acknowledge, I'd like to thank God for health and strength during the period of study. I'd also like to thank and recognize my supervisors, Dr. Godfrey Mayoka, who's from the School of Pharmacy, Jomo Kenyatta University of Agriculture and Technology, Dr. Bernardine Lusweti, who is a pediatrician at Thika Level 5 Hospital. I'd like to thank Thika Level 5 Hospital administration for the permission to do the study at the place, Pharmaceutical Society of Kenya for this platform to do this presentation, and to you, my audience, for listening to me. Thank you so much. I hand over back to Eva, the moderator.
Thank you so much for your presentation. It was a wonderful presentation on pain management, I think, which is very important because it's one part of the process that is normally left to mainly the nurses of the family to deal with. So we should be able, as pharmacists, to know how to plug in and to assist the patient and to give the patient the right advice. And kudos to you for doing that research. Now, please remember that all your questions should be put on the Q&A and will be answered at the end of the presentation session by all the presenters just before we go into our panel discussion. So kindly put all your questions on the Q&A chat and we'll be able to answer them. So next, I will go right into the sponsor address. Astrazeneca is our title sponsor, and we must thank them for coming through for PSK. And I'm going to invite Mr. Spencer Holt, the head of commercial learning and development for Astrazeneca Global, to tell us about resilience during change. Welcome, Mr. Spencer Holt. Can you hear us?
Yes, I can hear you. Can you hear me?
Perfect. We can hear you perfectly.
Oh, good. Well, good morning, everybody. And thanks for having me on. I'm really excited to be able just to share a few words as you start off this amazing conference. And I'm hopeful I can share my screen. Is that going to be able to work?
Yes, you can share your screen. It's going to work.
Okay, perfect. I think you need to stop. Oh, there we go. I was going to say, I think it gives me that. Okay, so I'll share my screen. You guys let me know when you can see it. Perfect. Everyone can see that now?
Yes.
Excellent. Okay, I'm going to do something. I'm hopeful that I'm going to do something that allows us to be a little bit interactive, if that's okay. So I'd love for you guys, if it's okay, I know we've got a bunch of people on the call, in the chat function, just really quickly, if you would, just tell me where you're dialing in from, what city or town or the geography that you're, I know it's all in Kenya, but I'd love to know the little cities that we're doing. That would be amazing if everyone just quickly put in there. Oh, Nairobi, thank you so much. Lots of Nairobi, excellent. So this, got some other ones, Kuwait, awesome, thank you. This is going to be interactive, and I'm gonna have you use a couple times the chat function so that you are able to share some of your insights. So as they're coming, oh, these are great. Now I have not been to Kenya yet, but it's high on my list. I spent some time in South Africa a little bit with my wife and my parents, and we absolutely loved it. So we hope to get to Kenya at some point. So I'm going to, just before I begin, the title of this presentation, and again, it's just, we're going to go for about 30 minutes here, is titled Elastic Bands or Chewing Gum. And so what my hope is to give you something to think about as we go through change, and how do we, as regardless of the stage that we are in our career, how do we demonstrate resiliency? And so before I do that though, I'm just, you guys will, I'm going to do a quick 1 minute or less introduction. This is who I am, because I think it's important that you know a little bit about me as I, and maybe perhaps why AstraZeneca asked me to share some of these thoughts. So as you can see, here's my family. I've got 4 amazing children and my lovely wife. I am, and the reason why I shared this picture versus the one where maybe everyone was looking, this is really real life for me, right? Like everybody in this picture resembles kind of how I picture what everyone's doing. So, you know, if I go to the right corner, there's my son. My son is actually 19 years old. And, you know, he's, you know, sometimes too cool to do the family picture thing. My other son there, his name's Ty, who's looking up at him. He's 14, and Ty loves to tell him what to do. And And then my daughter, who's the far left, where all you see is the back of her head, was worried about her hair and was trying to get her hair right. And you can imagine how that goes sometimes with a teenage daughter who is absolutely amazing. She's so happy. And then my Josh is the 12-year-old who still listens to us as parents and thinks that we're cool. And so we love him. And then there's my wife. We have, I'm originally from Alberta, Canada, and my undergrad was in finance, and I love that. And these things around these pictures are different places that I've worked. And so I grew up in Canada. I did my undergrad in finance. I worked for a bank when I first began, the Bank of Montreal, and I worked there for about 6 months. And then I became, I had some clients that bought a company, and I ran a small oil and gas company at 27. And you can imagine at 27, that's fairly young to run a company. And it was a small company. It was only about 8 people, but I was 27. Everyone else was 45 or above. And I quickly realized I didn't know enough about people or leadership that I should have to be able to run this company. And I realized I barely knew, I did not know enough. We made a couple mistakes. We did a couple things right. And we ended up selling that company. And I moved to the United States, and I started to do my master's. I did my master's in adult learning. So why do people do the things that they do, and what makes effective leadership? And at that time, I then started to work for Astrazeneca, and I did a bunch of different roles there. But then I eventually did my PhD, and my PhD was in particular organizational theory. How do we develop change, and what does change management look like? And so that's what I'm super excited about to talk about today is how do we, regardless of what we're doing in a pharmacy or we're going to school or wherever we're at today, how do we start to demonstrate really effective leadership habits that will help us be resilient, that might help both the organizations that we work for and the patients that we serve to be resilient in this time of change. And so thank you everyone for kind of letting us know where you're dialing in from. I'm gonna hopefully switch my slide and it works. Okay, so the title of this presentation is Chewing Gum or Elastic Bands. And so if you think about it, in times of change, we can sometimes demonstrate, if you think about a chewing gum, you can chew it and you could chew it for a while and it breaks down and it comes together. Or I want you to think about an elastic band that stretches and comes back. And if you had to demonstrate the properties of either chewing gum or elastic band, which properties do you think you would rather demonstrate? In the chat function, and I'll share with you which answer I think is right, and you'll be able to decide. But don't be worried. If you had to describe which property you'd rather demonstrate, which would it be? Chewing gum or elastic band? Put it in the chat function. Ready, set, go. Okay, we've got a couple people putting some answers in right now. Lots of elastic bands, a couple chewing gums right now. Chewing gum, it tastes sweeter. We got lots of elastic bands, and we got another chewing gum there. Excellent. So I'm going to share with you a thought of the difference between chewing gum and elastic band. Now, think about this. What elastic band can stretch and stretch during times of change. If you stretch an elastic band too far, it will break. Also, if I stretch an elastic band, it goes back to its original shape. Where chewing gum, if I can chew it during times of change, it can pop, but chewing gum will always bind back together, but it will take on new forms or new shapes, and it evolves with its environment. And so one of the things that we love to tell people is during times of change, we do things and we try things, but we don't want us to go back to our original shape. We want us to continue to evolve. And so we often will tell people, we want you to be more like chewing gum than we want you to be like elastic bands. And maybe this presentation will help us decide why. There is a really kind of a unique term that we use to describe our environment today, and it's called a VUCA world. And VUCA very easily just stands for volatility, which V is unexpected and unstable market conditions, so volatile. U stands for uncertainty, lack of information or unforeseen changes. C stands for complexity, where many interconnected parts there are variables and there's lots of moving pieces. And then A stands for ambiguity. So relationships are unclear or unknown. And oftentimes with the world it is today, you'll hear it sometimes described in the business world as a VUCA world. And some people, you might be listening to this, you're like, oh my goodness, that not only is the outside world could be VUCA, some might even describe the organization that you work for VUCA. I often will sometimes say with 4 kids, sometimes my family feels like a VUCA world where there are so many things going so quickly. And what we used to talk about in terms of leadership is that we used to reward great leaders for their ability to predict and plan for the future. But with the way that the world changes today and how quickly the market conditions can change, we will often tell leaders today, we need you to be able to sense and respond, to recognize that it's not about having all the right answers, it's that ability to sense what's happening and to respond to it in the moment. And so as you think about this VUCA world, how many of you can relate to that? How many of you can think about in your own world, or maybe your own organization that you're involved in, or maybe the school that you're going to, that you can see this volatility, this uncertainty, the complexity and ambiguity? And so this presentation today, and now for maybe the next 20 minutes, I'm going to give you 4 tips to be more chewing gum than elastic bands. And the first one, and this is some really great research actually out of, there's a couple different places where we will take this information, but one of these things is from a Harvard Business Review and some really great organizational scientists that talk about, in order to be resilient, we need to have confidence. And I love the picture on here, because oftentimes during change or uncertainty, it's not easy to be confident. And what the literature tells us is that it's incredibly important that during these times of change, and in order to be resilient and to be a little bit more chewing gum than elastic band, is that we should not be afraid to take risks and to take smart risks, but don't be afraid to try new things. Oftentimes, what we tell people is that with the rate of change today, and if you think about scientists and how we discover new medicines, is that oftentimes the skills and capabilities that made us successful in the past are not the same skills or capabilities that will help us be successful in the future. And that we will need to take risks and try new things in order to solve things differently, because the challenges are new, and that we'll have to show different ways to solve new problems. And they will often describe leadership as a way of helping us take smart risks and to help people recognize that our most innovative scientists, our most innovative leaders today are ones that aren't afraid to take risks. Number 2 then means that we're not afraid to make mistakes, and that when we innovate and we try things, we will fail, and that it's okay to make mistakes. It's can we admit to those mistakes and to learn from them. And so some of the most successful people in the world today are those that are not afraid, that they have this heavy dose of humility. They are confident, but yet humble, and demonstrate humility from showing people that they're trying new things, making mistakes, but they learn from them and then apply them in whatever that they're going to do. And then this third principle in being positive is around the understanding of, what positivity does and how it can help us in everything that we do. Positive is one of my favorite books, is called Delivering Happiness. And of course, it is a book by a Harvard professor who kind of gives 8 effective habits of how you can start to really condition yourself to be positive, and what that does both for you in your life, but the people that are around you. So what that looks like is number 1 principle or habit on being more chewing gum than elastic band is confidence. Okay. Our second one is, hold the door. Second one is, I want you to think about your social support. This is one of my favorite ones. So social support starts to think about as we, what was the name of the book again? The name of the book is called Delivering, actually the name of the book is called The Happiness Advantage. I'll actually, I can even put it in the chat function. Great question. Feel free to ask any as we go along. It is one of my favorite books. I read this book at least parts of it every year. I absolutely love it. So great question. So I want you to think about your social support. One of the ways that we are more chewing gum than elastic band is around the people that we surround ourselves with. So I'm going to reference a lot of books, and I can, of course, share all of them at the end. But there's a book called by Benjamin Hardy, Dr. Benjamin Hardy, it's called Willpower Doesn't Work. And he talks about the power of influence and how our social support, the individuals that we surround ourselves with, shape who we become. And that in order to ensure that we are more chewing gum or that we are resilient, I'm going to ask each of you to think about, am I surrounding myself with people that are helping me be more positive, that I can learn from them, and that they keep me resilient? And I'm going to give you an example. And the reason why I've got this, are you in the jar or outside the jar? I'm going to give you an example. In this book, Willpower Doesn't Work, you've got Benjamin Hardy talks about an example of fleas. And he says, if you study fleas can jump very high. But he goes, if you put fleas in a jar and you tighten the jar for 3 days, the fleas will only jump as high as the jar. And if you, after the 3 days, when you take the jar off, the fleas have been conditioned to only jump as high as the jar, and they won't jump any higher. In this study, it's not until you take the fleas out of the jar and then you put them again with other fleas that are jumping super high that they begin to jump higher again. And in this book, he makes a very strong correlation that as humans, we oftentimes will only jump as high as the people around us. And he tells us to be very intentional about the people that we are interacting with, and ensuring that we are surrounding ourselves with leaders of people that will help us jump higher, and to stretch our thinking, and to help us to recognize that our environment or the individuals that are around us are incredibly important. And so that's why number 1 here on social support, being resilient, one of the ways is being intentional about the people that we surround ourselves with. Can we learn from them? Are they stretching the way that we think? And so that's why number 1 is there. Am I inside the jar or am I outside? The second principle of social support that I'm going to encourage you to think about, and this one is called establish a second brain. And I love this concept. So this establishing a second brain, I want you to think about second brain is a thought partner. And some of our very best and most effective leaders in the world today are individuals that receive, coaching. They're not afraid to ask for help, or they have somebody that they are constantly involving themselves with. And they have a partner that they can consistently talk to say, I'm going to use you as my second brain, where they can talk to somebody without fear of judgment. And that this individual that they talk to can ask them questions so that they think differently, and that they are challenged by this individual, so that they're not stuck in a way of thinking just one way, but they're opening their eyes and their brain to a second way of thinking. And so I'd love for you to just pause for a minute and think about who in your life can serve as your second brain. Is there someone that you can consistently have a visit with, or talk to, or set up time with, that that can serve as a thought partner or your second brain? I've got somebody that I consistently talk to, if not once a month, sometimes twice a month, depending on what I'm working on, that I use as my second brain, where I get, whether it's 45 minutes to an hour, where I just get to ask that individual questions, or I share with them what I'm working on, and they ask me questions. So I expose my thinking, and I'm able to be challenged in a way that maybe I wouldn't be if I didn't have this support or this individual set up. So I would encourage you, think about who is your second brain that you're able to talk to on a regular basis, that stretches and challenges the way that you think. Okay, so that's our second habit of becoming more resilient. The third one is adaptability. And so I want you to think about this. Adaptability is understanding your failures and then reflecting on them, being open to new ideas and situations, and finding ways to complete difficult tasks rather than giving up. Learning to become adaptable means trying to identify and deal with any self-sabotaging personality traits, such as fear of uncertainty or change. And what I love about the principle of adaptability is that what the research tells us is that individuals that, think about like chewing gum, is that, they can, regardless if the bubble breaks, the gum comes back together. And it's able to be put back together and then stretched again and gone in different shapes. And even if it breaks, we can form it back to something else. And adaptability is just that, recognizing that we are going to make mistakes, whether that's in our professional career or our personal lives. Recognize that that adaptability is something that our most successful leaders today have, because the world today is changing so quickly, and that their adaptability and their ability to try things new, to make mistakes, to fail, to try again is so important. And I love this last sentence where it talks about that we are able to overcome any self-sabotaging personality traits, such as fear or uncertainty or lack of self-confidence. And oftentimes, it's not that those things might not exist, but that we figure out ways to overcome them. And I love the picture below. I love this just simply because oftentimes where we might think of something happening one way, the most successful people are going to recognize that maybe the big balloon that we thought was going to carry us is actually, it looks much different, and it might not be nearly as big. It might be small. In fact, I'm a big believer that small things make a big difference. I do a podcast every week. I have a podcast. It's called Small Things Make a Big Difference, and it's around leadership insights. I'll share the link in the chat function. You're more than welcome to listen to any of the episodes. They're about 20 minutes long, but they're leadership insights that oftentimes talk about principles such as adaptability. Okay, so there's the third one. The fourth principle is the power of purpose, which is probably for me one of my most important principles around being more chewing gum than elastic band. The power of purpose comes down to that individuals that are secure in their purpose and have clarity of who they're trying to become are individuals that have that ability to be successful and to get up after they've been knocked down and to continue to try even when things are not going right. The other really interesting thing about individuals or leaders about purpose is that when you experience somebody that has a strong sense of purpose, that purpose unites other people, that purpose lures people to follow them, and that purpose really matters when it helps. I'm actually going to share really quickly a link, and this link is to one of my podcasts where I interview the CEO of Duke Corporate Education. His name is Michael Chavez, and Michael Chavez is absolutely brilliant. He's super smart, but he recently just wrote a book called Rehumanizing Leadership. And in this, Michael Chavez talks about the power of purpose, both within an organization and also for individual leaders, and how that when we begin with purpose, we start to build a foundation that allows us to be really successful, not only within organizations, but within the lives that we lead. Okay, so I recognize I'm almost out of time here, and I'm loving some of these. I like this. Shouldn't we have started with power of purpose as number one? Well, we could have, absolutely. In fact, the power of purpose is the foundation, and I maybe saved it till the very end so that it's potentially maybe the last thing that you heard me talk about. I do one of my favorite workshops that I do, actually now almost all virtually, is around helping people identify their own purpose. And we go through a series of questions, and so that individuals have what I like to call a purpose statement. And I love these comments that are coming in around making sure you have a definite purpose and how that makes your legacy. I'm going to give you one last book reference because I think it is such a great book. Clayton Christensen he wrote many books on innovation. In fact, he was a Harvard business professor that wrote, the first book he wrote was called Innovator's Dilemma. And he was often termed the innovator, the godfather of innovation. He wrote so many books on it. Towards the end of his career, he wrote a book, How Will I Measure My Life? And it is such a great book about the power of purpose and recognizing that when we begin with an end in mind, understanding what we stand for and who we're trying to become, it helps us to be really intentional in the lives that we lead and the individuals that we impact, but more importantly, how we act in any situation is so important. And so, my friends, as we come up to this introduction or 30-second or 30-minute intro, I'm going to ask you a quick question. We went over 4 principles today of purpose, adaptability, social support, and oh, I'm sorry, my mouse stopped working. Social support and, of course, confidence. If you had to choose one of these 4, like one of the 4 that you resonated for you, Which one would you build more on today? Which one resonated with you? Confidence, social support, adaptability, or purpose? Go ahead in the chat function, put that down really quickly, please. It'll be great. And there's no, obviously there's no right or wrong answer here, as all of them are really important. And lots of purpose one, which doesn't surprise me. Just so you know, in this in the podcast, Michael Chavez talks about how purpose is developed over time sometimes. I love the one around confidence, social support. Social support for me, the second brain. Oh my gosh, may we always find somebody in our lives that will challenge us to think differently. I love that one. I love reading these. Really, these are great. Thank you for putting these down. And also, I hope that it has helped in identifying maybe just one area that you might try to grow in the next little bit here. And so finally, I'm going to give you one last thought as I close and leave you with. And you can see there's a picture of a motorcycle here. Now, I don't ride motorcycle, but I came across this example. 2014, Jason Roney is a 14-year-old, actually, no, pardon me, not 14, he's 12. So at 12, Jason Roney is the first 12-year-old to do a backflip on a motorcycle. And if you think about that, I'm like, 12 years old, that's incredible to be able to do a backflip on a motorbike. And it was funny, as I read this, I went to my son, Josh, who you saw at the beginning of the presentation, who was, he's 12. I was like, Josh, this guy can do a backflip. And he looks at me with these big eyes. He's like, oh my gosh, this is incredible. How in the world can you do a backflip at 12? Well, what makes this even more incredible is that when motorcycles started, like in the mid 80s, motorcycle riders would never have done a backflip. It was considered impossible. And what happened was, all of a sudden, there was a couple motorcycle riders that decided to start trying to do backflips, and they started to ride these jumps and were trying to do it, and they would land in little ponds and rivers, and they started to make videos of them. And over time, these videos started to be shared, and so people started to see people started doing backflips. And so more and more people started to try them. And all of a sudden, people's context of what was possible started to change. And it wasn't until, though, in the mid 1990s, the first backflip was ever done. And then it was in 2002 that the first backflip was done. In 2005, the first double backflip was done. And then it was 2012 that the first triple backflip was done. And all of a sudden, riders, people that were into motorcycle riding, their context changed of what was possible. And so it wasn't that motorcycle riders in the 1980s didn't believe backflips couldn't be done, is that they didn't believe it was possible. And today you have 12-year-olds and now 8-year-olds or 9-year-olds realizing, not only can I do a backflip, but they're now starting to try to do other different crazy tricks that they would have never thought possible, all because of examples, and that their context of what they believed was possible started to be shaped.
Lo umesikia baridi? Asante.
Well, I think we got somebody not on mute. We might want to go on mute there.
Ajafika.
Okay, so my friends, I wanted to say, like this example, may you expose yourself to diverse thinking, and that you'll recognize that as you start your, whether it's early in your career of pharmacy or late, that there are many possibilities of what you can do. And so I hope you have an amazing conference, that you are more chewing gum than elastic band, and that you find great success in all that you do. Thank you so much for letting me be part of this. And I hope you have a great conference in terms of realizing your potential and your great role in what we do in medicine today, improving the lives of patients that we see and that we interact with. And so thank you. I really appreciate you allowing me to be here today.
Thank you so much, Mr. Spencer Holt. That was a refreshing talk, because we are in a point where we need to be very resilient about everything we are doing. The pandemic has actually showed us a new ways of doing things, and we need to be resilient to be able to survive through this. And we really thank you for that presentation. It was very refreshing. Next, I would like, hello, can you hear me? Next, I would like to invite the next speaker for abstract, Dr. Victor Mudhune, to talk about the pipeline of HIV prevention interventions. What should pharmacists do? Thank you. Karibu sana, Daktari.
Thank you, Dr. Mai, and good morning, everyone. I think it's a challenge to be asked to speak after such a powerful presenter, but we hope that we'll be up to the task. Well, mine is to present on what does the pipeline really look like. I don't know if you can click on the next slide, please. Thank you. So mine is really to present on what does the pipeline really look like with regard to possible HIV intervention that are now and in the future. It will be a packed 20 minutes. I was told to make 15 slides, but I was able to make double the number of slides. So I hope that we'll be able to absorb all the content within the limited time that we have. Next slide. Next, please. Next slide. Slide number 2. So we all know the background with regard to HIV pandemic. We know that we have about 38 million people who are living with HIV. We know that the burden is mainly in sub-Saharan Africa. You're seeing the red section of the map there. And even 40 years after AIDS was first discovered, and a lot of progress really made with regard to treatment and prevention, we still have about 690,000 people dying from AIDS and AIDS-related complications. Next slide. Now, the details closer home is that our HIV prevalence is actually reducing, which is a good thing. It's now at about 4.9. Our incidence is also reducing, pretty low. We still have counties that we are defining as hotspots. And these are actually areas of concern where prevalence is significantly high. We have a high number of people infected with HIV. These areas are mainly within the region that are next to Lake Victoria. If we look at the 1990 UN target, and we are just looking at the adult population, we are seeing that we are doing very well with regard to the second 90 and the third 90. We still have some gap to cover for the first 90. But again, if we incorporate pediatric and adolescent data, then we expect these percentages to actually go down. And generally, we are still not at the 90 yet, but I think we are almost there as a country. Next slide. So the big leap really, happened sometime in 2012 when that blue pill, and this is one of the 2 key blue pills, was actually approved for HIV infected individuals. And the government of Kenya really did a very good job. We were one of the first few countries to actually implement PrEP and be able to roll it out. And we currently have the implementation project, but it is actually being scaled up in most of the government health facilities. The message out there is very clear that Jilinda is PrEP, and we all know about it. And on the map that you're seeing on the right, just a preview of the areas that are around Western Kenya that are actually actively providing PrEP to the at-risk population. Next slide. Next slide. So we are stepping back and looking at what is the background of PrEP. Why did we decide on this particular medication? And the blue areas on that table actually the first few studies that were rolled out. Most of these studies were actually on women. The initial evidence was really, really poor. There was really no efficacy. It was not very clear at the time why there was no efficacy. But further studies were done incorporating men. It was realized that PrEP actually does work, and it only works when it is taken. And what was also discovered in the further study was that there was a challenge, particularly with PrEP taking behavior in women, especially young women, and they needed other options to be able to show that we can still protect themselves against HIV. Next slide. So the next slide really shows you that for you to expect increased protection efficacy, then we really expect the adherence to equally increase. So on the y-axis, we're actually seeing adherence increasing with increasing level of efficacy in all the studies that have been conducted with regard to PrEP in the past. Okay. So then what really people need is what you're calling options. The key message here is that there's no one product that fits everyone's lifestyle. There's need for mechanism or modes of representation of the drug to be fitted into an individual's lifestyle. And again, we also note that an individual's lifestyle also does change with time. What works for me now may not necessarily be what works for me in 5 or in 10 years' time. And again, so now essentially what you're looking for is, we need to find modalities and different implementation methods that we can roll out. Next slide. So I don't know if you heard about this particular product, but it's the current FDA approved alternative to the commonly known Truvada. It's called Discovery. It was approved in October 2019 as an alternative to FTC TDF. And it has the active ingredient of FTC TAF. We look at what TAF is and what TAF entails. Next slide. Okay, the people can speak to the chemical structure better than me, but what TDF and TAF are, they're actually prodrugs of tenofovir, and that within the body they are converted to the active form of the medication, which is tenofovir. The TDF is an ester, and the TAF is an amidate derivative. And the issue with TDF is that if we give it with caution, people who have impaired renal function and the people who have issues with bone mineral density. And the reason why that is a particular concern to TDF is that it builds up high level of plasma tenofovir, which is actually related to that particular side effect. So there are studies that are ongoing with trying to compare TDF and TAF, and that's actually concluded, and I'll talk a little bit about that particular study. Next slide. So what you're seeing here is the evidence that was actually published sometime this year in the Lancet journal. And the study that was done in Europe and North America among 94 communities in that particular area. They enrolled about 5,800 cisgender MSMs. These are men who are born men, but they have identified themselves as men who have sex with men. And they're at high risk of HIV infection. So they did conduct a double-blind, placebo-controlled randomized study where participants were randomized in the ratio of 1:1 to receive Truvada or Descovy. The objective of the study really was to compare the safety and efficacy of these two medications. And can talk a little bit about the results. Next slide. So the graph on the left basically just shows you the HIV incidence per 100 person years. The green box shows you the incidence in the population that received TAF, and the gray column shows you the incidence of the population that received TDF. What you're actually seeing is there are 15 infections in the TDF arm compared to 7 infections in the TAF arm. You can see that the confidence intervals of the incidence rate kind of overlap. That tells you the difference is not really significant. On the right graph, we actually comparing the confidence interval of the incidence rate ratio. And we're making a decision point at 1.62 non-inferiority margin. And what you're seeing that is stretching more towards 0 and a little bit crossing the 1. Crossing the 1 tells you it's not significant, but again, when it's moving towards 0, it tells you the outcome is really in favor of TAF as opposed to TDS. So the study was designed as a non-inferiority study, so we cannot say it is superior. We can only say it is